program. James?
Hello. All right. Can everyone hear me okay?
Yes.
Lovely. So as Serena said, my name is James. I am an outreach case manager. I'm very excited about today's webinar. It's really great to be able to talk to people in other parts of the country about housing because there's lots to compare in terms of knowledge and experience. On a personal note, I'm also very excited because it's gotten up to a balmy 9 degrees here in Boston. So we're very excited that it's an early summer here for us. So as Serena said, today's topic is about housing the homeless, particularly marginalized individuals. And our goal for today is...
All guests have been muted. You can unmute your line by pressing *6.
Can you hear that? Okay. Sorry about that. So we're just, going to talk a little bit, and I want it to be a casual conversation backed up with interesting thoughts, opinions, and data. I want to hear about people's successes and some barriers and strategies because, the thing about knowledge, especially around housing, and especially around housing resources, is it doesn't stay the same. It changes very, very quickly according to funding and geography and the patients we're serving and a number of other circumstances. So, I'm looking forward to hearing how different agencies handle common housing problems. At the root of housing advocacy is communication, and by that I mean communication with patients and also communication between providers or advocates. So, I just want to say that, our case managers might be your patient advocates, might be someone else's, peers. There's a lot of overlap in this field. So I just want to talk a little bit about the phrase housing advocacy as I understand it, which is, and also a little note, I'm technologically challenged, so if you hear me groaning, it's because I'm trying to manage slides while talking. I'm the old guy who can't figure out the remote at home, so that's me. And I pressed the wrong button. Oh, there it is. All right. All right, so if you do housing search or you refer to legal people who specialize in housing, or you view an apartment with a patient or a client, or you refer to a furniture bank, or you do budgeting, all the things listed on this slide, then in some way you do housing. It's always a team approach. And I think something even as seemingly minimal as talking to someone who's housed about how things are going and identifying, supports that you can put in place is a form of housing advocacy. So when we talk about housing advocacy, we take a really, really, really broad view of that. And the thing about housing advocacy is that it never ends. Going to a slide. It never ends. So you help people with finding housing, and then you help support them while they are housed. And then, there are occasional cases where, or maybe not so occasional cases, where people lose their housing, and you work with them then to either sort of figure out the next steps or get them rehoused. This is all housing advocacy, and very, very important stuff that you're probably already doing already, so just pat yourselves on the back for that. And then there's a blank slide while we transition to the other presentations, but I just wanted to thank you for being here, especially people where, it's early in the morning for you and you're probably having your first cup of coffee. Thanks for being here.
Thanks, James, for welcoming everybody and opening us up and setting the framework for the discussion. So this is Serena again. I just wanted to say there may be some technical glitches again, so just please bear with us. We appreciate your patience. So the one thing I also forgot to mention is that there is a chat function. So for those of you who would like to write or a question or comment, you can use that piece as well. You just have to, it's on the right-hand corner, the right-hand box, and you just write it in the space bar there and then hit send, and it will go to everyone. We'll see your question. So to our first speaker, I want to introduce our second speaker. James will come back on and talk a little bit more in depth about Boston Healthcare for the Homelessness program. But I'd like to introduce Verna Gant, who is Program Manager for HIV Support Services at Family Health Centers in San Diego, and she's going to talk about their approach with housing. Verna? Oh, and Verna, remember to unmute. Hit *6.
Okay, thanks, Serena. I'm unmuted now.
Okay, great.
But good morning, everyone. And I'm excited also to be on this call and just to hear the difference in the housing approaches throughout the country pretty much because we're in different locations. But here at Family Health Centers, the medical case managers has taken a lead role with navigating the housing spectrum to assist HIV-positive individuals with short-term, emergency, transitional, and permanent housing. And we have 2 locations where we have case managers stationed, which is our HIV Coordinator Service Center and then also our HIV Prevention Center. Today I will cover the following objectives: define permanent supportive housing, define Family Health Centers' approach to housing advocacy, and describe how housing needs are assessed by Family Health Center staff, define populations Family Health Center serves, list available housing resources in San Diego, brief description of trainings provided to staff regarding housing advocacy, explain barriers to housing and barriers to individuals staying housed for HIV-positive population. And finally, at the end, we will have questions. Permanent supportive housing as defined by the U.S. Department of Housing and Urban Development. Permanent supportive housing is an evidence-based practice for housing advocacy that is described as long-term community-based housing that has supportive services for homeless persons with disabilities. This type of supportive housing enables special needs population to live as independently as possible in a permanent setting. And this really fits the criteria for many of the clients that we've served over the years in case management as it relates to housing. The supportive services may be provided by the organization managing the housing or coordinated by the applicant and provided by other public or private service agencies. Permanent housing can be provided in one structure or several structures at one site or in multiple structures at scattered sites. There is no definite length of stay. And as James alluded earlier when he started his presentation, that oftentimes clients may lose housing and then we're challenged with trying to find other housing that meet the criteria. Family Health Centers' approach to housing advocacy and how housing needs are assessed by Family Health Center staff. Family Health Centers' main approach to housing advocacy is the belief in the evidence-based permanent supportive housing. Family Health Center places a high regard on assisting chronically homeless and or disabled clients with getting safe, stable, and permanent housing. The SPINS project allows Family Health Centers and PATH to coordinate efforts by providing housing for chronic homeless, dual-diagnosed HIV-positive individuals. Family Health Centers Peer Navigator work closely with PATH outreach worker, case manager, and a leasing agent to link clients to PATH's housing program, which is known as Connections. Housing needs are generally assessed based on the client's past housing history and current financial situation. Some examples would be a client with a chronic history of homeless or a low fixed income. Those clients will be viewed as having a need for housing assistance and advocacy. The population that Family Health Centers serve, our mission statement is that Family Health Centers of San Diego is dedicated to providing caring, affordable, high-quality health care and supportive services to everyone with a special commitment to uninsured, low-income, and medically underserved persons. Family Health Centers serve every population, high-income, low-income, uninsured, disabled, HIV-positive, and everyone else in between. As it relates to the SPINS project, the program serves chronic homeless, dual-diagnosed HIV-positive individuals. The collaboration with Family Health Centers and PATH is a strength for addressing mental health, substance abuse issues, and establishment of a primary medical home, which would break some of the barriers for stable housing. Bear with me, I'm not on the webinar. Okay, the list of available housing resources in San Diego. We have the Section 8 Rental System Program. The Housing Authority of San Diego, the Housing Authority of the County of San Diego has programs for low-income households to help them pay their rent. A portion of the rent is paid on behalf of the families directly to their landlords. Emergency shelters provide temporary emergency shelter for homeless individuals. San Diego Rescue Mission, Brother Bino, Salvation Army, St. Vincent de Paul Village, Africa Project, Catholic Charity, Interfaith Shelter Network is just a few of the programs that we use to refer clients to. The Peer Navigator will work with all clients to ensure they complete an application for the Section 8 Rent Assistance Program. The wait list is currently 8 to 10 years, and there are no priority housing for individuals living with HIV disabilities. With HIV or other disabilities. Another housing program here is called the Hopper Housing, which is housing opportunities for a person with AIDS. Hopper funding provides housing assistance and related supported services, and this is really a key resource for us here in San Diego because not only do the participants have housing, but they also help them with other supportive services to help maintain and help to identify stable housing for the participants. Family Health Centers has established MOUs with the local Hopper providers here in San Diego for comprehensive transitional housing services. In collaboration with PATH, the Peer Navigator and Case Manager will work close together to ensure clients are meeting their housing plan goals. Training provided to staff regarding housing advocacy. The main source of staff training comes from in-services provided by Housing Assistance Program staff. These in-services provide staff with the requirements needed to assess the assistance provided as well as any updates to the Housing Assistance Program. Barriers to housing for the HIV positive population. There's limited access to housing assistance programs. Housing is the most prevalent need among people with HIV and AIDS. Although San Diego County has a comprehensive housing continuum with a range of housing options, there is simply not enough housing assistance to serve every person living with HIV/AIDS who needs help. Limited resources and incentives for affordable housing development of housing that is affordable to people living with HIV and AIDS has become increasingly challenging. Currently, very limited funding options are available to housing developers. This is particularly evident in 2009 due to state credit and budget crisis. The information dissemination is another barrier. People living with HIV/AIDS consistently noted that widespread dissemination and understanding of housing program information is lacking here in San Diego. Service providers that focus on HIV services or housing, as well as those outside the system, do not feel they have complete and current information about program availability and eligibility. Barriers to individual staying house for the HIV-positive population, sobriety. Most housing assistance available for those living with HIV/AIDS require clients to be sober and maintain sobriety from illicit substance use, including alcohol and marijuana. The location sometimes can be a barrier also. Some housing assistance programs and some housings are located in unattainable locations. Confidentiality also presents a barrier at times. Many people living with HIV/AIDS fear that living in an HIV/AIDS apartment complex or housing situation could lead to their confidentiality being breached. The Connection Housing, a partnership between Family Health Centers and PATH, is an integrated service and residential community whose primary goal is to help homeless individuals living on neighborhood streets rebuild their lives and secure permanent housing. Virtually every resource an individual needs to break the cycle of homelessness will be available on the site at this facility, including 73 permanent supportive housing units, 16 special needs single-room occupancy units, 134 interim housing beds, a one-stop social service center, and a family health center and primary care medical home on the first floor. And this is the conclusion of my presentation.
Oh, thanks, Verna. This is Serena.
You're welcome.
Thanks for sharing what's going on in San Diego with us. And I just want to open it up to our audience. If people want to raise their hands or unmute their phones, that's *6 to ask Verna some clarification questions. We'll take one or two questions before moving on to our next person. I have a question.
Okay.
Verna, you mentioned that in this initiative, the SPINS initiative, with connections to housing, you have your partner's path, and we'll hear from Katie in a minute about some other other housing resources that you all are in your approach to housing. But in your initiative, you said that you have peer navigators that are going to be working with case managers.
Yes, we have one peer navigator who's already beginning to work with the case manager to identify individual for housing.
Okay. And is that HIV case managers and housing case managers?
No, it's not necessarily HIV case manager.
Okay. So they'll work on the housing issues. And did I hear you correct in that the peer navigator, one of their roles will be to work with clients on applications?
Yes. And one unique thing that we've already established here, our peer navigator actually have worked out a situation with the leasing agent where they actually come on Family Health Center's site to do the enrollment and to meet with the client. Because many times our clients have barriers, with transportation. And so it's an added plus that she's able to actually come on site and do the intake with the clients.
Okay. But that'll be a navigator role, not necessarily a case manager role.
It would be the navigator role as it relates to Family Health Centers, then it would be the case manager role as it relates to PATH.
Okay. Great. Thanks for clarifying that.
You're welcome.
And you said in your area it takes 8 to 10 years?
Yes, for the Section 8. Unfortunately, the wait list is extremely lengthy here. And so one thing that we do with case management at intake, and once they started working with a client, the first thing that's on their housing plan is to enroll with Section 8 so they can at least get on the wait list.
And there's no priority status on that? Is that
No,
correct?
That's correct. No priority for HIV/AIDS nor any other type of disabilities.
Is that a California rule or San Diego rule? Like, I'm just throwing it out. I'm new to housing, so I'd be interested to hear from other sites if that's the same situation.
Well, from my experience with housing, it's a San Diego rule. I know one time I worked in Los Angeles, and I don't recall the waiting list being so lengthy, and also it may be related to the lack of funds also.
Actually, this is Katie. I can speak a little bit to that because we work with different housing authorities across Southern California, and basically each housing authority sets its own administrative plan, which is locally established, and they have the choice whether they open it up to prioritization or not.
Okay, so
it depends on the local housing authorities.
The local level. Okay, great. Thank you. Okay, just in the interest of time, since I don't see any other questions coming from our audience, I'm going to move on. Katie, can we move on to your presentation, please?
Absolutely.
And this is Katie Hill. She is from PATH, People Assisting the Homeless. And PATH is Family Health Center's partner in this initiative. And Katie's the managing director for PATH. So, Katie, go ahead and take it away.
Awesome. Thank you. I'm taking a little bit more of a general, broader approach regarding our philosophy towards housing and some of the issues that we face and the things that we've found to be helpful. So I'll try and move through it pretty quickly, but let me know if you have any questions at the end. Just some brief background on our organization. Our mission, we have purposely made our mission very broad, and it's to end homelessness for individuals, families, and communities. We provide the full range of housing, including interim, which is otherwise known as emergency housing, transitional and permanent supportive housing, as well as supportive services to homeless individuals and families throughout Southern California, all the way from San Diego up to San Luis Obispo. Our focus is we're very focused on serving the most vulnerable individuals, including the chronically homeless, veterans, and people with serious health conditions, as well as families. So we actually, PATH is comprised of 5 different nonprofit agencies that each sort of specialize in a different area so that we can basically create an entire continuum of services. Our main philosophies to housing are that you cannot do it unless you are creative, you collaborate with other agencies, and you are flexible in terms of embracing change. The main areas that we work on are street outreach, so we're literally taking people from the streets all the way through permanent housing. rapid rehousing for people who maybe are not homeless for quite as long and just need a fast solution to being able to get back into permanent housing, as well as permanent supportive housing, both scattered site and in housing development. Some lovely pictures of our clients. Our approach is individualized. That is that we're committed to providing the right housing intervention for the right person at the right time in the right community. And you'll notice that I'm very specific in terms of saying the right each and everything. And because we truly believe that without any part of that, you're either going to experience extreme delays in terms of housing people, or they're not going to be successful. So if you put somebody, just because there's a housing option, I mean for us, in South LA, doesn't mean that somebody who's coming from the East San Gabriel Valley is going to be able to live there and be successful, because community integration is key. We're innovative, so we're always adjusting our service delivery models and creating new models. Connections Housing is one of those, where we actually have the Family Health Center's clinic on site. We have, we're calling it the Path Depot, which is a variety of different service providers providing everything from legal assistance to case management to mental health and substance abuse counseling, all in one location, as well as 150 interim housing beds, which is short-term emergency shelter, and permanent supportive housing. So it's the entire continuum in one building right in the heart of downtown San Diego. So that's an example of one of the models that we're testing, I guess. We use evidence-based practices from motivational interviewing to critical time intervention to permanent supportive housing, and the reality is that no one, evidence-based practice is going to work for every single individual. So you need to have a team that's truly trained and able to adapt to the individual client's needs. And then we're community-based, so we rely on partnerships and community integration to ensure the long-term success of each client. That's pretty self-explanatory, but what it really means is that since we are so spread out and so broad geographically, our partnerships with the local entities and the local providers who are truly ingrained in each of those areas is absolutely critical, because they are completely in tune with the neighborhood resources and the resources that the clients are actually going to use. We use a Navigator approach, which is sort of a case management philosophy, and we talked about it a little, Verna talked about it a little bit, but it really is designed to prevent high-needs clients from falling through the cracks, which is something that tends to happen if, you say, okay, here's your referral, go over to this housing provider, and then take your bus tokens, go get your ID. The reality is that so many of our clients are truly, truly disabled, and we really have to do a lot of hand-holding. The Navigator philosophy blends 2 times tested strategies, which is street outreach, literally meeting people where they're at, and case management combined with peer support and harm reduction. So the goal is basically you're completely non-judgmental and you're willing to do whatever it is that the client needs in order to get them housed, whether it's taking them to the DMV to get an ID or to the Social Security office, or teaching them how to do grocery shopping or clean their apartment, whatever they need. And then it connects the dots between all the different systems somebody has to encounter in order to end their homelessness. So it's working with the housing authorities, working with the mental health system, working with the healthcare system, working with the other service providers. And it's a very complex range of services. I mean, I've been in the homeless services field for quite a while, and you still learn something new every day. So it's unreasonable, in our opinion, to expect clients to be able to successfully navigate that on their own in many cases. And then this is basically a time-tested strategy that is proven to be the most effective in helping chronically homeless and high-needs individuals get off the streets across the country. So we switched to this approach about 3 years ago, and our outcomes have significantly improved since then. So this is some of our outreach team, which are basically the acting navigators, and you'll see we literally go up into the hills and where people are sleeping in the bushes, or whether it's in urban areas or whatever. I wanted to talk a little bit about how we screen for appropriateness in terms of, since there are so many different housing resources, the case manager's role is really to point the client in the right direction. So we use an intake and assessment tool that helps case managers determine the appropriate housing options and develop a housing plan with the clients from the very beginning. So from the moment we encounter them, we're working with them on what the housing strategy is going to be and how long it's going to take them to do that. So it's important to have that framework. It's not saying, okay, meet this milestone, you need to get a job, or you need to get clean and sober, or you need to do X, Y, and Z before you even think about housing, which is the way it used to be. Right now, it's housing focused from the very beginning, and everything else is considered part of the objective in getting you housed. Our case managers are trained and provided with a flow chart of the various resources that are available, which, as was mentioned earlier, is constantly changing, and which direction they should point clients towards depending on their specific situation and needs. For housing subsidies, Section 8 is the most common. We have developed a pre-screening tool to use the Housing Authority's eligibility criteria to ensure a high rate of successful applications. Because if you have a client fill out a Section 8 application and it's filled out wrong and it gets sent back to them, I mean, that can delay the process for a really long time, months in some cases. Or they can get denied for something that's, they think they're eligible, but if you aren't completely familiar with the admin plan and the criteria that each housing authority has for you to be eligible, then it could be a complete waste of time and getting the client's hopes up, and that is really something we don't want to face. Our housing resources that we typically use consist of the Section 8 homeless set-aside. This set-aside concept is something that many housing authorities have, where basically they say, okay, we're taking a certain amount of vouchers off of the top of all their Section 8 vouchers and setting them aside specifically for homeless individuals. So for PATH, we're actually contracted by the housing authorities in many different communities to administer a portion of those homeless vouchers. So we actually are able to set the prioritization on our own, and we have basically almost complete control over those vouchers as long as the clients meet the criteria. So for us, that's incredibly helpful in terms of being able to really basically put our most chronically homeless, most vulnerable clients at the top of the list. There's also Shelter Plus Care, which is administered through the local continuums of care. There are Hopway and Ryan White subsidies depending on the region. There's HUD-VASH, which is a key housing resource for veterans. PATH is actually administering 1,100 VASH vouchers across Southern California on behalf of the VA. So again, we were able to work on streamlining access for people who are most vulnerable. And then there's move-in and short-term rental assistance programs, which are key in terms of being able to expedite a person getting housed, because if they don't have the move-in assistance funds, somebody who's making $200 a month from general relief or something like that is not going to be, it's going to take them months to be able to save up enough for a security deposit that's $1,500. So we prioritize getting them towards different kinds of move-in assistance that's available. And then the reality is that subsidies, there just aren't enough of them to go around. So we really have put a lot of emphasis over the last couple of years in terms of linking clients with market rate housing, whether it's through shared housing opportunities. So two people who are living off of SSI with $900 a month can in some cases share an apartment and be able to afford it. So we work with them on different kinds of strategies that sometimes get overlooked by providers who have been used to being able to use subsidies for their clients. Our commitment is to basically help 3,000 people make it home over the next couple of years. So 1,000 families, 1,000 veterans, and 1,000 chronically homeless. We rely, as I mentioned before, heavily on critical partnerships. These include volunteers and faith-based groups. There are one of the needs that sometimes we feel gets overlooked in terms of clients is that, yeah, you get them into housing, but they don't have anything that they need to be able to actually live in an apartment. They don't have a bed. They don't have furniture. They don't have towels or dishes or sheets. So we organize volunteers and faith groups to create basically what we call move-in kits, where we partner them with a client. The client provides a list of their needs for moving into housing, and then the faith groups actually organize it and kind of throw like a welcome home party for the clients, and that's been one of our huge successes. The housing authorities are a relationship I cannot stress enough. If you have a good working relationship with the housing authorities, you'll be able to move mountains in terms of, within your own community, creating a set-aside, and it's all about breaking down barriers, and traditionally there have been challenges in terms of the working relationships that homeless providers had with the housing authority, because they, are tough to work with. They're not easy. It's very challenging, slow, very bureaucratic in a lot of ways, but we've, over the years, have been able to develop relationships with them, and they've literally changed barriers to housing because of our recommendations, and I can't even tell you how far that's gone. Again, government agencies, for us, it's the Department of Veterans Affairs, the Department of Health Services, the Department of Mental Health, housing departments, the continuum of care, even law enforcement in many cases. We spend a lot of time working with our local police so that if they encounter one of our clients, they can actually call us. And in many cases, we can work with them and go pick them up so that they don't have to actually press charges. They'll, work with us on that front. And then local cities, for us, LA, everyone thinks of LA, but there are literally, I think, 88 different cities in LA County, and each of those has their own politics and their own, leaders that have their concerns about the homeless. So it's developing those relationships and working within the neighborhood groups like business improvement districts, neighborhood councils. It's really important if you want to be successful to be a good neighbor. And then hospitals and clinics are obvious. They help us identify frequent utilizers, establish a medical home, and address the client's health needs. Local service providers and nonprofits. We host local collaborative sessions with different, like I said, there are many smaller providers, and we have to get them together so that everybody can streamline and strategize in terms of working on the same list of the clients we serve. And landlords and property management companies. The vast majority of our housing is tenant-based scattered site, meaning that we need to cultivate landlords and work with them on issues so that they continue to prioritize our clients, work through the cumbersome process with the housing authorities, and allow us to intervene and advocate for our clients when issues arise so that we can prevent eviction. And again, I mentioned customer service here because without all these partners, we literally could not do what we do. So we educate our staff to treat all of them, even when they're a challenge to work with, in the same way that we treat our donors, because they're effectively donating us the resources we need to help our clients to find and maintain permanent housing, whether it's apartments or housing vouchers or support systems or health care or furnishings. Every part of it is critical. And we feel the same way about our clients. At the end of the day, we exist to serve our clients, so we always treat them with dignity and respect, even though in many cases they are challenging. I mean, we have clients, who get bogged down by the system and feel so frustrated that they take it out on our case managers. So we have to work with our case managers to really work on the de-escalation techniques and always taking the client's concerns as our first priority. So I know I talked for a while, but thank you for listening. That's it.
Thanks, Katie. That was really informative. Thanks for all that information. I want to open it up to take one or two questions. And there is one question from Carl in Jacksonville for you. It says, where are the Section 8 homeless set-asides?
Do you have specific housing authorities that you're working with, Katie?
Yeah, for us, we're working with the Housing Authority of the City of LA and the County of LA. They're two separate ones, as well as in San Diego. So those are the three that have designated homeless set-asides that we're actually contracted to administer those vouchers. But those are the only three those are the biggest three, so they're the ones that really have the ability to do set-asides more easily. But we're working with other smaller housing authorities to consider it as well. But it's taken years for us to get there. So.
What size of set-asides have they given for you? I mean, how many are they setting aside for you?
So if for City of LA, past portion of set-aside vouchers is, I think at the latest count, it was up to about 175. But that's just PATH's portion. We're also a partner in a county-wide collaborative that's working with the City Department of Mental Health, the County Department of Mental Health and the County Department of Health Services. So we're administering those set-asides, which is 250 vouchers a year for 2 years, specifically for chronically homeless who are linked with those two health systems. I don't know if you all have heard about Home for Good, but it's an initiative that's being pushed by United Way. It's gotten a lot of national press, and they've been able to really change some of the systems and get these these big departments to work together, and that's kind of the outcome of this effort. And I encourage you all to look at it because it really can be looked at as a model in terms of getting community stakeholders together and setting aside resources and things like that.
Katie, this is Serena. So that's great information. It should be on their website, you think? Or if we just Google it, we can send it out?
Yeah, if you Google Home for Good,
Yeah.
Los Angeles, you'll find it.
Okay, great. Thanks. Just in the interest of time, I'm going to move us on to our next presenter, but Katie, one other question that came in is if you would be willing to share your flowchart of resources.
Yeah, absolutely. I'll send that to you.
Great, thanks. Okay, so I'm going to move on to our next presenter. We'll come back again to open it up for discussions if people have more comments or questions, particularly for Katie and Berna. But at this stage, I'd like to introduce our next speakers. Carl Falconer, who is Senior Director of Housing and Homeless Services, and John Pauley, who's the evaluator. They're with River Region Human Services in Jacksonville, Florida, and they're working with the University of Florida's CARES Clinic on our SPINS initiative. So Carl and John, I'll turn it over to you.
Thank you very much. This is Carl. I'll be doing most of the talking because if I let John talk, we'd be here all day. But other than that, like was mentioned already, we work for River Region Human Services in Jacksonville. And unlike James, we're cold down here. It's about 65 degrees right now. So it's getting cold for us down here, and we can sympathize with that. We have 11 housing programs currently serving approximately 350 clients with River Region. River Region provides a comprehensive array of services. We actually, housing is only a small portion of what we do. We provide HIV outreach, prevention, intervention services, substance abuse services, case management, supportive housing, and mental health treatment as well. We do have two SPINS programs actually that we are working on currently. One is a HOPWA SPINS grant entitled FUSE, or Forging Useful Systems to Empower. It's for 40 families, and we also have families who are HIV positive. And then we also have the HRSA SPINS grant, as mentioned, which is called the Path Home program. And our goal is to build a medical home embedded in an affordable housing residential complex and provide stable, affordable housing for homeless and unstably housed, multiply diagnosed people living with HIV and AIDS. For the past 12 years, River Region's been using several SAMHSA recognized evidence-based practices, a lot of the same ones that have already been mentioned, permanent supportive housing, harm reduction, motivational interviewing, peer support. We also use Housing First, which hasn't been mentioned yet, but I'll talk a little bit more about that in a second. I've broken our presentation down to talk about the different things that we have, or the different things that we do, the philosophies that we take. The first is, of course, our screening and our intake. The screening instrument itself should be short, simple, and precise. It should help determine eligibility for the program and gather basic information about the potential client. So when you're looking at creating a screening instrument or taking a look at your current screening instrument, you want to make sure, again, that it's short, simple, and precise. And really, the screening instrument should be about eligibility and not contain a whole lot more information. The concept of Housing First, we use that currently, which means that we try to get people into housing in the shortest time frame possible, meaning that we try to knock down a lot of the barriers that other programs might have, such as sobriety, and were mentioned before, some of the other barriers that were mentioned before. They don't have to be, people don't have to be housing ready to move into our housing programs. We move them into Housing First, then we allow them to receive the services that they need after that. Our screening staff are truthful and open, and we ask them to be that way with the potential client. the screening we see as a chance for the potential client to ask questions and to determine if the program will be right for them. It's also an opportunity for the program to build rapport with the client while we're doing the screening. But again, the screening is looked at as an opportunity for the client as much as the program to determine whether this is going to be a good fit for both the client and the program. We use motivational interviewing techniques, and they can be very helpful. It lets the client know that there's an opportunity for the program to help them make their own lives better. Our goal is to instill hope, and that can lead them to changing their lives for the better. Again, it's really about the client understanding that they have the power to make the changes in their life. And we also use peers. And one of the reasons that we do that is because it really, particularly for the screening and the intake, that initial contact with, in this case, the peer network navigators, allows the people to be as open as possible when they're talking with the potential client and when the client is talking to them about our program and asking questions. Hold on one second. The role of the case manager or the peer navigator is really to build rapport with the clients. It's to gather the necessary information from the clients and to assist the clients to achieve the best possible life they can achieve. Again, it's about assisting. We take a philosophy that it's the client's life. We should not enable them or entitle the client to anything. The client must realize that it's their life, and the staff and the program is here to assist them doing better in the program. Also, the client or the staff should not take anything personal when it comes to case management. What we found is, particularly working with people that are directly off the streets or have been homeless for a long time, they often have not had positive relationships with others, and oftentimes they're used to using what we call street rules to survive, not society's rules to get along. And we really understand that if we can take that role as staff, then we don't have to take it personal when we realize some of the behaviors that our clients exhibit towards us. Staff also should not take credit for any successes or failures, and by that I mean that the clients determine the success and the failure of the program. Too many times I think we get wrapped up in our ability to help people, and that's a great thing, but we also have to understand that really it's the client that's making the changes and the client that really has to do the work if they expect their life to really get better. And finally, the staff should get the client to focus on their goals and positive changes that they should make in their life, and these should drive all of the discussions and all the decisions that the clients in the program are making. And finally, housing units, absolutely. After you have the clients, obviously you have to have the housing units. There are a lot of clients and there are very few housing units in most areas. We have an idea here that we try to create housing units, and so particularly at my level, at administrative level, that's really what I'm trying to do for our programs, is trying to come up with creative ways to create more housing units. The first one that we have idea is partnering with developers. We actually talked with a program here, and they are one of our partners that we're working with on the UF Cares program. The program's name is Ability Housing. They actually were a housing development agency working with people who are developmentally disabled. And we asked them to start looking at developing some units for our homeless persons, and they changed over, and now they primarily build more units for our housing programs, or our homeless programs, sorry. The second is to leverage the volume of units. This helps us drive the prices down in the market when we do have to use market leasing. An example is if you get one or multiple agencies walking into a single landlord, it's easier to negotiate a lower price and to be able to get more units for those prices. And then finally, partnering funding sources. We're currently in the middle of writing for a grant where we have one funding source is currently funding the social services aspect for the program, and we're going to another funding source to fund the housing portion of it. The housing portion that we're looking to get funded is a state agency, and the federal agency currently is working to provide the supportive services. And that's all I have for mine. Thank you.
Thanks, Carl. I'm going to open it up to see if anybody has questions for Carl. Take a few clarification questions or about services in the River Region area. Anything coming through? Carl, so this is Serena. I have, as you were talking, how did you go about working with housing developers?
Well, it's interesting because our initial reaction was we looked into the possibility of River Region actually being a housing developer ourselves. And we actually did develop some housing that way. But in the midst of trying to become a housing developer ourselves, we realized that there was a whole host of other developers out in the community that were already developing housing. They just weren't doing it with our population. So we started approaching them, and we started sitting down and talking with them about the possibility of them building more housing units for our populations. And they started realizing that there were other funding sources and resources that they hadn't tapped into yet to be able to do that. So that's really how it came about for us.
And how long did it take you to build those partnerships? I mean, I can imagine some developers weren't interested, others were.
Well, it's interesting because it really didn't take us that long to build the partnership with the agency that we have. And the reason is because it was really, really competitive in their market that they were trying to build units for. And when they started taking a look around at the resources that were available to build units in our market, it was actually an easier market for them to get into. And so they were more than happy to switch over because it was easier for them to continue building more units in the market for our population.
So again, it goes back to the local market situation. And
yes.
Understanding this correctly? Okay.
Yes, absolutely. Yes.
That's great. Thanks. That's really helpful. I'm just trying to understand how I create these partnerships if I need to find more housing units. So thanks for that.
Sure.
Anyone else have questions for Carl? Okay, so in the interest of time, I'm going to turn it back over to James. He's our final presenter here, and then we'll open up for questions. So I hope everyone can stay on for a few past 1 o'clock. Go ahead.
Yeah, I may actually go over a little bit, but I'll try and not talk too fast, but finish up at a reasonable time. I did just want to say to Verna, Katie, and Carl, I'm really blown away, and John, blown away by sort of how much thoughtfulness goes into the interactions that you have with the populations that you serve. People think of housing as sort of this binary thing, but they don't realize the complexities of it, and a lot of that is focused on the interactions, the individual interactions, and the interactions as a whole. And you all, from these slides and from hearing you speak, sound like you're doing a really, really great job of that. So thank you. So my presentation, can they see this?
Yeah.
Okay, so what you're looking at right now, if you're looking at the slides, is a picture of where I work. Boston Healthcare for the Homeless, our Gene Yaki Place location. So this is the main health center, although we provide care in a number of different locations. This is the main site. I've been there for just a little bit, but this organization as a whole goes back to 1985. And this location is relatively new. It's located right across the street from Boston Medical Center, which is formerly known as Boston City Hospital. It's a very large hospital, and we have an affiliation where people, we use some of their facilities at times. We send patients over there for x-rays and other appointments on a regular basis. Our site is has a number of different components to it. So there's the ground floor, which is the outpatient clinic, and then the upper floors are medical respite, which is called, also known as Barbara McGinnis House. And we also have our administrative offices. So in terms of providing care at locations in and around Boston, we have 80 different sites, including 2 hospital-based clinics and many shelter clinics. And every year we serve 11,000 unique patients, which is a lot, and the staff is around 300. So within this location, I work on a small team sort of located in there, and we serve HIV-positive individuals. Our approach is multidisciplinary, and housing advocacy is certainly a big part of that. I think from some of the other presentations, I mean, you talk to people, and housing always comes up as a need in one form or another. I think it would be an understatement to say that our patients generally have complex lives and complex health needs. Anyone can enroll to become a patient in our clinic. There's no geographic restrictions. People just, have to be homeless or have a history of homelessness and present and say that they would like to enroll in medical services, and we're there for them. We have plenty of patients who we've housed who continue to receive care at our health center, so we don't kick people out once they get housed. So in terms of the questions, I went chronologically. So in terms of our agency's approach to housing, we believe that housing is a good thing and that there's not enough of it. And I think everyone here on this call could say the same thing. The housing process is a lot like case management. It is, like Carl said, it's all a question of fit and knowing the individual, and also knowing about housing resources, and being familiar with our patients' individual needs. It really allows us to sort of match them up with housing that will be conducive to better health, which is our goal. Placing a patient in unsuitable housing can have disastrous consequences, and we really work closely with our patients to reinforce that that housing is not the building that they will be living in, but more importantly, a home that they can go to where they feel safe and they feel comfortable. So in preparing for this webinar, it kind of struck me that Boston Healthcare for the Homeless's approach to housing mirrors our approach to healthcare. We strive for a holistic approach, and we really try and consider the individual at all times. So how you work with a patient really depends on what their housing history is, who else they may be working with, and what affiliations they currently have. So sometimes patients think that working with more housing advocates will yield better results. I think you all know that that's not the case, that it can have, it can create a lot of confusion, both for the various people they may be working with, and also it can delay housing. So we really try and talk to people about, who their support network is, and try and make sure that, they're working, that if one person, that they work with one person on housing and that person take the lead. That's very, very important. The other people, the other providers and people at different agencies can sort of support that work, but someone has to be appointed sort of like the lead housing person. I think it's really important to take a really thorough housing history and really find out sort of where they have been up to the point where you're initially meeting with them, both in terms of their housing and the other circumstances of their lives. But, it's hard sometimes because I think sometimes, because the patients we work with have such complex lives, I think sometimes they may forget something about their housing history, something really important, or they may forget something about their CORI, again, something really important, and that can sort of pop up unexpectedly. So, sometimes it takes a while to get to know the person that you're working with, but it's worth the time if you're going to do effective housing. Okay, so we're housing resources in Boston. We're already at that slide. Boston has a lot of housing resources. But if people have been to Boston, it's kind of a wacky city. I think the person who did the layout of the city had a funny sense of humor. It's not a grid system like other cities, New York and Los Angeles. It's really, really dense, and then it kind of, once you get out to the outside of like the downtown, it kind of spreads out a little bit, but it's definitely not grid-like. It's a really challenging place to try and house folks because we have the third highest rents in the country, right behind Los Angeles and New York. But we don't have some of the benefits that Los Angeles and New York have. In terms of like providing affordable housing for the patients that we serve, the big players are Boston Housing Authority and Metropolitan Boston Housing Partnership. Both of these agencies offer affordable housing for low and moderate income individuals and families. We do a lot of work with both places. Boston Housing Authority manages 64 public housing developments throughout Boston, and they also own and manage scattered site properties throughout the city. And these properties represent 14,000 units that house 27,000 people. In addition, they administer about 11,000 Section 8 vouchers that allow families to rent in the private market and apply that, a subsidy to their rental amount. So BHA provides housing to about 25,000 people under that program. That's a lot of people, and still there is not enough housing in Boston. Metropolitan Boston Housing Authority is the state's largest regional provider of rental housing voucher assistance. They primarily serve homeless, elderly, disabled, and low and moderate income individuals and families. They administer federal Section 8 vouchers as well as MRVP vouchers, which are the Massachusetts Rental Voucher Program. They have specialized voucher programs for specific populations, including veterans, elders, and people with disabilities. And they also have funds available for homelessness prevention, and they have a program to help prevent foreclosure in Massachusetts. And they also have an interesting program that works with people who hoard. So they're pretty diverse and good to work with. But the thing with both of these agencies is they're just slammed with paperwork, and they're and they're being pulled in a lot of directions. So when I call, I always try and keep in mind what their daily volume of emails, faxes, and mail must be. And also, we collaborate with a number of agencies in and around Boston. These include meals programs, drop-in centers, mental health service providers, shelters, utilities assistance providers, aid service organizations, youth-based programs. There's an agency that serves HIV-positive folks leaving incarceration. There's a wide variety of services available in Massachusetts. Occasionally, patients relocate to another part of Massachusetts. We can certainly work to help them transition to care and transition to safe, affordable housing. I guess I just want to stop and sort of point out that housing can mean so many different things. For some, it could mean a detox. For others, it could mean like a program. For others, it may be supportive housing. Other people, want housing without any supportive services attached to it. For some of our patients, housing means prison. So you're just sort of, Carl was talking about, sort of working with the individual and really assessing their needs. Absolutely true. And housing is just, we're always sort of balancing, you sort of want to locate housing as quickly as possible. You want that to be safe and affordable housing. And you want people to be a little choosy, but you don't want their vouchers to expire. So it is kind of this moving target that really changes according to the individual's needs. In terms of populations that we serve, so the pauses here are me failing at monotasking. Forget about multitasking. So here's the populations of Boston Healthcare for the Homeless serve. We serve homeless men, women, and children in the greater Boston area. Actually, you know what? If someone lived in another part of the state, even on the other side of the state, and they wanted to receive services here, they certainly could if they were willing to travel. So we serve anyone who's homeless or who has a history of homelessness, as I said. And the team that I work on is the red team. So, you know, that's the team that people who come to our clinic who are HIV positive get assigned to. So in terms of our 250 to 300 active patients, mostly male, and mostly African American. Our program is unique in that we don't assign case managers or housing advocates to particular patients. You know, we always want to have someone on call. So people come in and they say, I need to see a case manager, and they're going to meet with one of our case managers. In some cases, you develop a particularly good rapport with an individual, and they're certainly welcome to request you as an individual. But I think it's hard when people come in, you know, they don't want to be heard, they don't want to be told, your case manager's not in, they'll be in next week, come back then. So we always want to have someone on site to meet with them. In terms of the exposure category for the patients that we serve, a lot of IDUs and heterosexual mode of transmission. And I don't think I put this on the slide, but according to our statistics, 97% of our patients on the red team have at least one mental health diagnosis, and I think that's really significant. Our team, you know, in addition to the 3 case managers, 1 AmeriCorps volunteer, 3 nurses, we also have physician's assistants, we have nurse practitioners, and a host of doctors. We really do want to provide care on demand. So I hope all of you, if you come to Boston, can give me a call for a tour. I'd be happy to arrange that. And in terms of defining housing advocacy, it's really just identifying what the person's housing needs are and doing your best to provide that for them. In terms of training and support that our staff receives, I think you all did a great job of pointing out motivational interviewing, harm reduction. I think these are really important tools. We really try and attend housing and housing-related trainings whenever possible. We have a new collaboration with the AIDS Action Committee, who are New England's largest and oldest AIDS service organization, to provide direct referrals to hands-on housing advocacy through them. And the great thing about the work that we do is, you know, we work as a team. Each one of us brings something unique and different to the table. We all have, you know, unique connections in the community. So we work as a team at all times. When I'm stumped, I go and ask my case managers if they can help me out. The problem is that we want to attend more trainings, but, you know, there's so much housing work to be done on a day-to-day basis that can be very difficult to just make it out of the office. So, you know, we usually identify housing needs at the initial intake, and those are followed up by periodic 6-month updates. We really want to find out with those 6-month updates, you know, whether we've succeeded at the goals that we've set 6 months prior to that, you know, reassessment, you know, how we're doing in terms of meeting their needs. We want to find out a lot at that initial meeting about collateral contacts, support systems, substance use, education history, employment history. And, you know, the intakes can be rather lengthy. We try and make them as conversational as possible. And again, housing always comes up as a topic. The best tool that I've found for housing is to really talk in plain language with the person that you're working with, to explain ahead of time that the housing process is a frustrating one. At best, it's frustrating, and that they really need to pace themselves. I remind them that it's like a marathon, not a sprint. There's a lot of anxiety involved in the process of getting housed, and we want people to really manage that anxiety. And we can, you know, we can connect them to mental health services. Also, I think it's important to instill an understanding of how housing can affect overall health and well-being, for the better and for the worse. I encourage them to think seriously about what they're looking for housing-wise. You know, think about it before we even start the housing search process. And I want them to hold out for housing that is more what they want than not. It's very rare that you find housing that's perfect. You know, we sort of take a piecemeal approach to housing, where if we can get someone into a place that they're comfortable in, once they're housed, we can start working on getting on waiting lists and identifying housing for when their lease is up, and that way it's not such a rush to find housing, because you don't want those vouchers to expire. And also, I really, it's useful for us if patients fill out what's called a universal housing application. It's a great way of recording what their housing history is and who they've been working with. And you can either do that all in one fell swoop, or you can do it sort of, in portions. Talking about housing, if people have barriers to housing, sometimes it's related to traumatic events, and you really want to help people, manage that. So if it's going to be sort of overwhelming to sort of take a housing history and talk about all this trauma that led to them losing their housing and not being eligible for housing, I think it's good to sort of break it up and really just sort of approach it as cautiously as possible. Almost finished here. So in terms of barriers to housing, it's illegal to deny housing, to people who have vouchers, but it happens all the time. I think sometimes people don't understand what subsidized housing or having a voucher is about. A lot of landlords don't understand this, or they might be nervous about having their, bringing their building up to code. So I think it's good to talk to when Carl was talking about talking with landlords, that can be hit or miss depending on who the landlord is. It always makes me very nervous talking with landlords, because some of them say, great, I'm totally into this. Other ones, not so easy, I'm finding. I think also another barrier is that housing authorities are overwhelmed with the requests for affordable housing. They are slow to respond. They do deny applications based on these small technicalities, and you have to appeal, or maybe a particular box isn't checked and they send it back. And Katie had said that can delay the process months. Yeah, absolutely. Also, there seems to be more readily available housing in dangerous areas and not enough in safer areas. I mean, it's hard to move someone who is sort of in recovery into an area where there's a lot of different triggers, or a neighborhood that may be unsafe for them. Also, I think patients' criminal backgrounds can be a barrier. They play a huge role in whether someone is accepted or denied. And there's an appeal process. Sometimes the decision to deny an applicant for affordable housing seems kind of random to me. So the rule is always appeal, appeal, appeal. In terms of housing myths, I think the biggest myth is that people see housing as some sort of finish line. For some patients, it certainly is, but it's just as common with people who are housed to discover that sometimes, the problem of not being housed is replaced with a new set of problems. Especially if the people living in that housing have little experience with being housed. I frequently hear from people who have spent a lot of time in the shelters that although they hate staying in the shelter, that once they're housed, they just don't know what to do with themselves. I think the shelters offer a lot of stimulation, for better or worse, and when people are alone in their apartments, sometimes that's hard for them. I think people need constant support throughout the housing process, and may even need the same amount, if not more, once they're housed. And for people that are housed, I mean, I think that sometimes when people are bored, they may relapse. I think, or if people are housed and they're bored, they may invite friends over to keep them company, or they might invite people in to party with them. People might invite people who, like family members who are not on the lease, to stay with them or live with them. And I think in neighborhoods, certain neighborhoods, there might be disagreements with neighbors, disagreements with landlords. I mean, all these things can cause someone to lose their housing. And I think coming back to the individual, the interactions with the individual, if you have a good working relationship with them, they're more likely to come to you if there is something going on. I mean, if there's a number of noise complaints and things are getting heavy at the apartment, they might, lose their housing. You want them to come to you before they get that 14-day notice. So I think that sort of checking in with people, or seeing people when they come into the clinic or the place where you work, and just checking in to see how things are going, and try and sort of use your intuition to detect any sort of anything that might be going wrong. That wraps up my presentation. Sorry I sprinted through that, but thanks for listening.
Thanks, James. So I want to take a couple of clarification questions for James about how Boston Healthcare for the Homeless program approach works. And then also, if people have general questions for our presenters, feel free to come on and raise your hand.
Did I put you to sleep?
No, I am interested, though. This is Carl again in Jacksonville. James, did you say that you do or do not have homeless set-asides with your housing authorities?
People can apply. We do have priority status. And really, the job of the housing authorities is to administer the vouchers or to administer the vouchers with agencies that we're affiliated with. There are set-asides. So we're relatively new. We're relatively new to doing a lot of housing work with individuals. I mean, I think in the old days we would refer out. There are definitely set-asides in Boston. I think it's more a question of how do you locate them and who do you work with. We would have no way of knowing that. I mean, we would have to work with an affiliated agency.
And you work, AIDS Action is a
We were-
group that would do that.
Yeah, I mean, we work closely with AIDS Action because they have money for rental assistance, utilities assistance, homelessness prevention. I mean, they're a natural ally for us. And they frequently have landlords contact them when when the landlord has available apartments. And they have a really good back and forth with the housing authorities. So they would know of available set-asides. But, I'm sort of bugging AIDS Action on a weekly, if not daily basis because, I do pick their brains about available housing.
So this is Serena, and then my question goes to all our speakers, Katie, John, Carl, Berna, and James. So it seems like there's different models of and the approach is the same. It's getting housing and connecting to the individual clients. And then, James, your model is Boston Healthcare for Homeless is HIV is a clinic that has now connects the homeless, and you're new in being a housing resources where it sounds like PATH and River Region, you are much more connected into the housing sector itself, right?
Yeah.
So for other grantees who may be more healthcare oriented and focused on that side, that might not have direct housing partners, I'm just wondering, particularly PATH and River Region, and James, you too, but how did you start getting connected into the housing situation? It seems like you all said you need to know the housing authority, maybe connect with developers, but are there other critical steps that grantees can take around housing?
Yeah.
I think the first thing, this is Carl in Jacksonville, I think the first thing that I would recommend for any of the healthcare providers is to look to your local homeless coalition, because you're going to run into agencies that are really more specifically working on those housing issues. And that's the first place to go, is to try to connect with them. If you talk with your local homeless coalitions, most of the time they can talk to you and figure out who might be a really good partner that you could start looking at when it comes to housing resources and somebody to work with to move you where you wanted to be.
That's great. And that's different from the Ryan White providers often. Are they also connected?
Oftentimes they're not connected, but there's usually a little bit of overlap. But at least in our community right now, our Hop with Spins grant, one of the goals for it is actually to connect those two systems of care, the Ryan White providers and the Homeless Coalition providers. That's one of our goals, is to do that, because we realize that that's not a link that we really have very strong in our community here.
Okay.
And also I think that, for places that have housing for, priority populations, I mean, you're going to be working with a health center or a shelter anyway to sort of collect that information, approve priority status. So, I mean, I think what Carl's saying is about sort of like the collaborative, I mean, I wish, there are meetings every couple weeks hear for people from different agencies that just want to talk about housing. I think that's always a great idea to just get together and compare notes, locally. But I think the hard part is that whenever you're working with a bunch of different agencies, everyone's schedule is different. It's almost impossible to get people in one room, which is why I like technology like webinars.
Thanks, James and Carl. Any other questions from our participants or comments? We have a few more minutes here. Okay, well, this is Rita again, and I want to first of all thank our presenters. Their contact information's here, so I really want to thank Carl, Katie, Berna, James, and John for taking the time to prepare this presentation, prepare their talks, and share information and experience with you all. I hope it gives you some idea of some steps to take in terms of what questions to ask about housing in your own area. They are the experts here. You have their contacts, so if you have questions or need some resources, please reach out to them or directly to me and Mariana. We'll connect you with people as well, because one of the goals of our initiative is to get people connected to housing. So how we can use each other across this initiative to help brainstorm ideas and strategies to help you get the work done in your own local areas is one of our goals here, particularly at the ETAC. So what we'd like to do is continue these conversations and these webinars. If folks have ideas for additional suggestions on what we might be able to come together as a group, maybe one idea is around talking more about barriers and how to address the barriers to housing in each area. But if other folks have ideas, please email Mariana and I with suggested topics, and we'll reach out to grantees to see who else is willing to participate in these webinars. So if there's no other comments or questions, I want to thank everyone again for their participation today. This has been recorded, so if you, and you do have the slides, but if you want to look at the recording again or share it with other staff, please feel free to do so. We'll make it available. And again, thanks to our presenters for taking the time out of their busy schedules to share their experience and information with us. So everyone have a great week, and we'll be in touch, and send us your ideas for other webinars and conference calls.